With regards to referring physicians, if patients have signs of emphysema,
we look at objective and subjective measurements. From an objective standpoint, we look at an FEV1 less than 50. For subjective measurements, we really look at patients who are short of breath or dyspneic on optimal medical management, or patients who are unable to do their normal activities of daily living.
As a pulmonologist, how I recognize which patient would be a great candidate for these valves. The basic of screening these patients, we want to get a pulmonary function test, and the certain criteria would be an FEV1 less than 50%. And in the residual volume, anywhere is considered to be greater than 150%. We also want to do a 6-minute walk test. We want to see that they're able to walk at least 100 meters. We still try to work with them. If they're not a candidate initially, we try to reassess them. Most of these patients are going to be short of breath on exertion, and those are the ones you need to recognize. Once we figure out a patient is a candidate for an endobronchial valve, we refer them out. Usually I have a conversation with my patient to see what comfort level they have, what distance they're willing to travel, if they're interested in certain centers. I think it's important for primary pulmonologists to develop a good relationship with centers that have endobronchial valves, because it's kind of a treatment that we both do together.
The nurse practitioners and the physicians in the office work collaboratively to make sure that the workup is complete.
When they're referred to us for treatment, we are really focusing on the procedure itself. We want to make sure that we get that patient back to the referring physician.